Welcome to the Sonosite webinar on ultrasound evaluation of the dorsal wrist. With us today, we have Daniel Shelton. Daniel Shelton is the Director of Musculoskeletal Market Development for Fujifilm Sonosite. Daniel spent 16 years as a dedicated musculoskeletal sonographer, and 10 of those years have been here at Sonosite. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. Daniel, I'll turn it over to you.
Thank you, Laura, for that introduction. Again, my name is Daniel Shelton. I'm the Director of MSK Market Development here at Fujifilm Sonosite. And today we will be discussing the dorsal wrist ultrasound. Indications from the AIUM are as follows: soft tissue injury, tendon pathology, arthritis, soft tissue masses, nerve entrapments, effusion, foreign bodies, and bone injury. Transducer recommendations can range from a larger footprint high-frequency linear to the smaller ultra-high frequency transducers, such as the one that you see here, the L19 on the right. So I actually like to have a larger footprint linear as a general survey, and it really helps me kind of see all the anatomy all at once while I'm scanning. And then when I do suspect pathology, or I really either can't find what might be a pain generator, or if I just need a closer look at something, it's really nice to have the L19 there. It does have a smaller footprint. It's roughly half the size of the L15, but I think especially today in the live demonstration, you'll see the difference between the two, and you'll see how nice it is to kind of have this L19, especially in the transverse of these tendons. I think the detail's really appreciated in cross-section. What we're going to be discussing today is the carpal bones largely and their surface landmarks, as well as the radius and the ulna. We're going to be looking at soft tissue landmarks like these joint recesses that we see here in the first and mid carpal rows. We're going to be cutting the extensor tendons in half so that we can see down them, and also going to be examining things like these little dorsal retinaculum that live on each of the extensor tendon compartments. We're going to be looking at these tendons and just kind of demystifying the direction all these tendons go once they've left the easy to scan area. So we have this diagram up here as a really nice reference, and you'll be able to use it in the recording to go back and reference where all these tendons go. But we'll begin on the dorsal wrist by covering the recesses first, and then we'll break to a live demonstration, and then we'll do the dorsal compartments, followed by the scapholunate. First things first, let's find our landmarks. You can palpate Lister's tubercle on the dorsal recess. That'll be a bony prominence just before the bend of the wrist in dorsiflexion. It's slightly radial to midline, but it's pretty close to midline when you're palpating. So I always start at Lister's tubercle when I'm scanning, even if I know I'm going over to compartment number 1. It's really nice to palpate this, put the probe down, and get an image of it. Distally, our landmarks are the scaphoid and the lunate, respectively, to form that scapholunate, not only joint and ligament, but it's a very good landmark when it comes to just navigating the rest of these carpal bones. And then the other more common landmark is the capitate. Here, it's a bell shape. You'll see it in the diagram. Less viewed, trapezoid is not typically a huge part of the exam. The hamate will be in the ulnar side just as a distal landmark, and the trapezium for CMC joint, which is not covered here, but we can do it in the live scan. Those are our major landmarks here, followed by the ulna and the ulnar styloid. Let's take a soft tissue slice here, and let's open this joint capsule in the first carpal row and take a look at the scapholunate ligament. It's a superficial component here. There's a superficial and deep. We largely just see, for the most part, the superficial component. But this is just an illustration to kind of give you an idea of what these synovial recesses are doing. They have a redundant fold, and basically the capsule extends not only over the joint, but past the joint, comes back and folds, and then inserts closer to the joint. And that just allows us to bend our wrist without stretching the capsule out too much. So it is nice to have that kind of range of motion to be able to be seen on ultrasound. We can flex and dorsiflex the wrist and watch this joint capsule in action, both for the mid-carpal recess and the first carpal row. Here in the animation, you can see there's a transducer orientation marker here. This large dot is representative of the left side of the screen. So we have this dot here, which will typically be proximal, and then when we go to short axis, depending on if it's a right or left wrist, just be consistent in how you scan, but just know that this big dot on the line is representing the left side of the screen. So I start in a mid-sagittal plane looking for any joint effusion just over the lunate and the capitate. If you see an effusion over the lunate, it's probably extended from the radius and lunate, that first carpal row, and we're looking right here at this little balloon. You can see there's a little asterisk there in the first carpal row's synovial recess. This lies just under the extensor tendon. So if you see a large effusion in the area, just know that the fluid collection can come from the joint or the tendon. The MRI correlation down here, you can see the radius, the lunate, and the capitate. And you can kind of see where the lunate gets its name, luna, like a moon. You can see how it's accepting of the capitate, and the capitate's just overall very bell-shaped, and you can see the surface of the bell of the capitate on ultrasound quite nicely. Moving radial now, so we've gone from midline, and now we're shifting over radially, and we have the left side of the screen still over the bony landmark of the radius, and then we see this almost a stair step where, we go back one slide, where everything was kind of in a row mid-sagittally, and you can see that the lunate it's got its own shape, it's more rounded, and the capitate's also very rounded, as well as the radius. When we move radially, you can see that the radius kind of has this abrupt stop, and then the scaphoid has this flat surface, which is very characteristic of this slice. So you'll know how radial you've gone once you see the scaphoid, and it's really, really flat, kind of stair-step geometry that we see here. You can even see a little slither of hyaline cartilage overlying the scaphoid. This is not necessarily the window that we would do a scaphoid evaluation for a fracture. For example, that's more coronal and volar, but this is cartilage on the scaphoid. So this is an intra-articular portion of the scaphoid. We're looking for the joint effusion here and here distally. This is a pretty classic example of an inflammatory synovitis case where we can see these little vessels of hyperemia invading the walls of those capsules that we just talked about. And really, you know, one artery over the capitate's pretty normal. You're always going to see this normal landmark of an artery that rests just over the capitate. But to see multiple vessels feeding into the walls of these distended capsules is abnormal and should be considered inflammation of some sort. And it's time to kind of look into the patient's history a little bit further at that point. So let's move to a live demonstration of that area over these recesses.
All right, so we'll begin with the live demo. I like to begin with a larger linear array transducer. It's a 15 to 4 megahertz. It's the L15 transducer. The larger field of view provides me a kind of a general survey of the gross anatomy and what's going on here. It's much easier with a larger footprint transducer to kind of associate if there's ganglion cysts, if there's tenosynovitises, what do they communicate with, and then to get a more detailed look at things, I'll switch over to the L19. So the 19 megahertz probe will really give us the ability to zoom in on what's going on with each individual either tendon or joint capsule. So I'll begin with the thumb orientation marker on the side of the transducer facing the radius and long axis. That's pretty typical. And the distal, the right side of the screen, will be facing the metacarpals. So in the long axis, what I like to do is just begin with the dot side of the probe right over mid-sagittal. And sometimes it's helpful to palpate Lister's tubercle. We'll talk about that in the next, when the slides start back up. But mid-sagittal is roughly Lister's tubercle, and we're just going to go long axis here. I can feel that Lister's tubercle under my finger, and then I just lay the probe down, and I don't want to collapse all of the soft tissue structures. So I started with a gel heap on purpose. When I start with a gel heap, what that does is it does not collapse the synovial information, basically. So if I have a joint effusion, which we're evaluating for right now, it would occur here in that first metacarpal row, or sorry, the first carpal row, or the mid-carpal row here. So in order, let's start with our bony landmarks. We have the distal radius, we have the lunate, and that bell-shaped capitate that we talked about in the talk here. So here's the neck of the capitate right there. More superficially, we have the extensor compartment of compartment number 4. And if we just kind of wiggle the fingers, we'll see that move. Here we are. Just above the extensors, right here, we see the extensor retinaculum. So we don't want to call that tenosynovitis. We don't want to call that any form of fusiform swelling or anything like that. So just know that the extensor retinaculum looks like this, just like it does kind of down in the flexor tendon of the hand, where it kind of looks like an airplane wing cut in half, and it is the strap that's holding everything down. If I'm looking at somebody else's pictures and I don't notice at least a sliver of a vein, one of these little dorsal veins, if I don't see those, I'm going to assume that they're applying too much pressure to see any synovitis, or they will collapse any joint effusions that we might have. So I'm going to pay attention to how much I see superficially. If you've already collapsed that vein and you want to get a really good look again and say, man, maybe I was compressing too much to see the synovitis, what I would coach you to do is find your cortical landmarks of the distal radius, lunate, and capitate. And then what you do is you just a little bit of firm pressure and then you let up quickly. And I can see this big, long, rectangular shape in the gel. And what I'm going to do is float a gel heap right over that. So I have this bead of gel, and what you can see, just like we do in some of the other superficial structures like the MCP joints, is I'm going to use my fingers as stilts. So I'm going to set those down here, and I'm just going to slowly rest the transducer's pressure in the gel first. And the effort here is not to collapse the gel. And if I'm not collapsing the gel or any of these subcutaneous veins, that means I'm not collapsing these synovial recesses that we're trying to evaluate. So here we have the radius, lunate, and capitate. So that's your mid-sagittal plane. And now what I'm going to do is I'm just going to roll the probe radially. As I go radially, you'll see the radius change shape. Here's Lister's tubercle in profile here. And that lets me know that I'm over compartment 2. I'm going to keep on going towards compartment 1, but not quite to compartment 1. And I see this kind of stair-shaped cortical change that we talked about in the slides. So we see the radius has a more abrupt termination here, like a step-off ledge. We see that the scaphoid bone here not only has a flat surface here, but a little bit of a hint of articular hyaline cartilage. And then above that articular hyaline cartilage, we see a synovial recess here. So we're looking for that first metacarpal row to show a joint effusion, basically. We will see a little bit of mid-carpal effusion here, but not as much as we would if we were mid-sagittal. So when I'm looking for a joint effusion, specifically in the dorsal wrist, I start mid-sagittal here and get the capitate in view, and then I work my way radially until I see that stair-step looking shape of the scaphoid and the radius there. Third window that I look for that was not on the slides, I go from mid-sagittal here and I pan ulnar. And as I'm scanning something like a wrist, a smaller extremity, whether it be the foot and ankle or the wrist or hand, I have to stay 90 degrees to the bones. I can't just keep the probe in its just sagittal axis. I have to convert to the sagittal oblique and then eventually coronal plane here. What you're not seeing on the camera very well is my fingers hanging down right here. And what I'm doing there is I'm going to palpate as I scan these bony landmarks. And specifically for the ulnar aspect, I'm feeling for the ulna, distal ulna and ulnar styloid right there. And that's going to tell me where I'm at while I'm looking at the screen. So as I set my finger behind the ulnar styloid and I rest the probe down, we see this really pretty picture of not only the ulnar, the distal ulna, and that prominence of the ulnar styloid here, which is right there where it terminates. We see the TFCC. We see the lunate. And we see the triquetrum. Superficial to all of these, we see the extensor carpi ulnaris tendon. So I'm also looking for any ganglion cysts or joint effusions. I don't normally see a lot of joint effusions this far ulnar, but it definitely helps to go ahead and scan to make a complete survey of that of these metacarpal recesses. Also, while we're in this area, we talked about the synovitis and what we look for in these dorsal recesses. There are normal synovial arterial flow structures that we don't want to confuse for synovitis. So let's just cover the one that sits over the distal capitate really quick. So let's put the arrow back on. Let's follow the capitate, the bell-shaped capitate here. And the very distal capitate right in this area, just past the neck. As I scan radial to ulnar, we see this little dark oval here. And that is a normal artery. And the reason that's important is when we're calibrating our color-powered Doppler, we don't want to call something like that synovitis. But if we see anything beyond what we see in this area here, especially a large collection of vessels like we saw on that last slide, it's definitely accurate to call it synovitis, because we should not normally see a collection of vessels anywhere in these dorsal recesses. So what I'm going to do is just activate the color-powered Doppler setting. I'm going to turn off the arrow. Now I will activate the color Doppler by pressing the C button on the key here. And I'm going to switch to CPD. And just over the capitate, we should see a nice little pulsatile artery. There it is. So if we're not seeing that really clearly as we are now, in some machines you just have to amplify the gain just a little bit. You can bring it up to what's called a noisy threshold. And you can see all the noise below the cortical level, and I'm going to reduce the gain just a little bit until below the bone we don't see any color-powered Doppler. So that artery on the distal capitate is normal. It is normal to see them just under the extensor tendons as well. And what we don't want to see is a bunch of vessels collecting around the synovial folds. But one or two arteries here, especially just under the extensor tendon, is normal. Don't call those synovitis. I'm going to exit out of my color-powered Doppler setting by hitting 2D. And that will conclude the longitudinal exam of the dorsal synovial recesses.
All right, we'll move on to the extensor tendon exam. There's a lot going on in the dorsal wrist, especially when it comes to the extensor tendons. So what we're going to do is just kind of methodically go through the compartments first. Primarily short axis exam is going to help you get through this with confidence first, and then we go long axis to just clarify any pathology. But for the most part, these are viewed in short axis. Now there's a lot of acronyms over here. We've got abductor pollicis longus, extensor pollicis brevis, then we have the extensor carpi radialis longus, and then we have the extensor carpi radialis brevis, extensor pollicis longus. There's a lot going on right here. So at least until you get to compartment 3, there is kind of a cool way to remember this. First is a lot of people talk about compartment number 1 as all peanut lovers eat peanut butter, and that kind of gets you going on the first compartment. So all peanut lovers eat peanut butter. So that really got me kind of a good start on how to memorize these if you feel the need to memorize them. And then from there, the second compartment is both ECRs. So it's ECR either L or ECR B. And then you have the EPL. So one way to remember the order that these go in is that you have a longus, and then you have a brevis, and then you have a longus, and then you have a brevis, and then you have a longus. So longus, brevis, longus, brevis, longus. So they alternate up until that third compartment when you're trying to, decipher the differences between the longuses and the brevises. How it ends, one way was told to me, this longus here, the extensor pollicis longus, that longus has the longest way to go. So it really does. This third compartment, this guy really travels very far up and over to your thumb, and we will, in the live exam, just wiggle the thumb and we'll be able to activate just compartment number 3 when we get over there. But that's a good way to just start off and how to memorize this acronym and make it a little bit less intimidating. So all peanut lovers eat peanut butter. And then the second compartment are ECRs, and then it's just a matter of whether or not it's a longus or a brevis. And we just went over how to tell if it's a longus or a brevis next, because they begin with longus, and then they alternate. Longus, brevis, longus, brevis, longus. So now that I've totally kind of muddied up your head on that, one thing I do want you to remember is that these compartments are also individually separated by their own retinaculum. So you can tell where one compartment begins and ends based on its little tubercles between the retinaculum. So each of these little prominences are insertion points to each compartment's own little retinaculum, and you're going to want to scan through the compartments transversely back and forth, kind of like we were scanning nerves, or we talked about the carpal tunnel. The easy way to scan nerves is to pick one and go proximal and distal when you're scanning relatively quickly. So I would do that here, and then just take a look at the bony landmarks. When you see a prominence there, you're going to see a little dark shadow insert on that prominence, and that's the retinaculum for each individual compartment. Let's start with compartment number 1, our all peanut lovers eat peanut butter. So we have the abductor pollicis longus and the extensor pollicis brevis. Start in short axis, bottom right image, and then if you feel the need to go long axis, then turn and check out each individual tendon. But like I said, for the most part, these exams are typically done in transverse unless you suspect some pathology. Now, see these little bony prominences? That's what I was talking about. And we're in compartment number 1, and you can see that it's got a little ridge on the radius on each side of the compartment, and then you can even see this little accessory ridge right here in the middle of the compartment. And in some of the patient population, there is a little dividing aponeurosis here, separating the abductor pollicis longus from the extensor pollicis brevis even, and there are multiple tendon slips located within this actual compartment as well. So that could be something that you see in there. Just don't confuse that for any pathology. When you do see one, you'll see this dark vertical shadow coming down to insert on this little prominence on the radius in the middle of the compartment. So don't let that throw you off, but that is the first compartment. And if you just call it first compartment, even when you're labeling it, that's fine. Don't go crazy identifying the individual tendons unless you see pathology and you feel the need to. Compartment number 2, we have the ECRs. So we have the ECR-L and the ECR-B for longus and brevis. Again, short axis is where we like to start here, and then we will follow up each one with a long axis correlation. So you can see the prominent tubercles that show up on each side of the compartment, and that's what's going to denote where our retinaculum begin and end. Just as an aside, from the tendons and transverse, we can see the superficial radial nerve just sitting right up here by this cephalic vein. We're going to move on to compartment number 3, extensor pollicis longus. This is actually one of my favorite ones to view, because we go back to our landmark of Lister's tubercle here. So we have this very large, very palpable bony landmark of Lister's tubercle here, and just dorsal to that is your extensor pollicis longus. And the way to view that, and we'll do this in the live demo, is just to wiggle the thumb. It's a very thin tendon, and you can see that here as it travels diagonally across the wrist over the scaphoid, that is where we will evaluate for the common intersection syndromes and de Quervain's tenosynovitis. In this area where you can have this intersection, not exclusively de Quervain's to this tendon, that would have been in the compartment number 2, but this can be a very abrasive site when we're scanning it, and we'll scan that in the live demonstration just to show how crazy its trajectory is. After it leaves the radius, it immediately heads towards the thumb. Here we have a video clip of the next group, which is your extensor digitorum and indices. Basically, you're going to take that short axis. Here it looks like kind of an egg over the radius, and just dorsal to Lister's tubercle, and then we're going to pivot and spin the transducer into a long axis back to our familiar dorsal recess view. In the video clip, there we go. And here it is, here, transverse cut of the extensor tendons. Moving on over to compartment number 5, extensor digiti minimi. Basically very small tendon. It rests right in the joint of the radius and the ulna, and you can see it just is suspended kind of like a hammock in its own retinaculum. So we have a retinaculum that sits on top of it, which is this dark triangular wedge, and then where it's not dark, it becomes bright because we have maximum reflectivity here, and then it dives down into its own retinaculum that bridges the gap between the radial ulnar joint, and it just kind of hangs there like a hammock suspended in this retinaculum. Here it is in long axis, very thin tendon, and you can see that we've crossed that first carpal row, and we're seeing an anisotropic TFCC here. And then lastly, compartment number 6 is the extensor carpi ulnaris, which has its own nice groove here. In this groove, we typically look for erosions too, especially in rheumatoid patients. That's where a lot of these erosive pathologies can be seen, is in the groove of the ECU. It does have its own prominent retinaculum here. You can see the change in the bony cortex of the ulnar styloid, or just before the ulnar styloid begins. So we have a groove, and on each side is a tubercle, kind of like a shoulder biceps groove. And on each of those tubercles is a start and end point for the retinaculum that we just talked about. So short axis first. If you feel the need to go long axis, this is a good view to also catch the TFCC deep, which is not in these slides today, but we can cover in the live view, live demonstration. Then after we leave the compartments, we'll go right back up to the dorsal recess view and go short axis, and then we're going to slide down to the scapholunate joint. So here you'll see the animation sliding down in correlation with this video loop until we see the scaphoid and the lunate. Radially, we got the radial side is on screen left, ulnar is on screen right, and we can see here's that Lister's tubercle. And then as we pan the transducer just distal to the joint, the first carpal row is where we see this V shape, this valley right here, and that's your scapholunate joint. And then here's that superficial ligament that bridges over the scapholunate. And then there is a deep ligament that we don't see a lot of, at least relaxed. You can do some stress maneuvers, have the patient squeeze a tennis ball, for example, and try to get that joint to open. Incidentally, over here on compartment 3, here, you can see that EPL traversing over compartment number 2. So here's your extensor carpi radialis brevis, and then here's the EPL sitting right on top dynamically. And we'll cover that in the live demonstration next. Moving on to the live demo of those compartments, as well as the scapholunate joint.
All right, so we'll move to the demonstration of the extensor tendon compartments. So what I like to do when I'm doing these is I still begin with the larger footprint L15. So start with lots of gel right over that footprint. Big gel heap, no air bubbles is pretty important. And then I palpate Lister's tubercle. So what I'm feeling for is this radial prominence. If I was comparing what I'm seeing here on the surface, it looks like it's kind of behind the second or third metacarpal. It's that radial to mid-sagittal. So mid-sagittal I'm feeling here, but I don't feel Lister's tubercle. And then slightly radial to mid-sagittal, I can feel Lister's tubercle right here. So what I'm going to do is just, I'm going to palpate that and take note of that. And then what I'm going to do is I'm going to place that gel heap right there. Again, so I don't compress the gel first, I've got my fingers back here like stilts, and I'm just going to slowly rest the transducer into the gel. And I'm going to activate the arrow on the machine. And first and foremost, we're going to find Lister's tubercle, which is this bony prominence right here. I may adjust the gain just a touch right here on the gain wheel. There we go. So this bony prominence tells me that I'm straddling compartment 2 and compartment 3. So I'm not anywhere near compartment 1. So let's begin with compartment 1, which will be way down here towards the table. What I'm going to do is stay 90 degrees to the surface of the radius and just roll the transducer over radially. I'm going to do a really quick survey of the compartments, and then we'll switch to the smaller footprint, more appropriate transducer for these compartments, which is the L19. So here I am on the extreme coronal side of the wrist, but I am still axial, and this is compartment 1. Take note of the two distinct tendon slips of the APL and the EPB. They'll be a lot more noticeable with an L19. Now I'm going to roll the probe over here to the ECRs. As we talked about in the PowerPoint, we have the ECRB, the ECRL and the